Good morning, everybody. Welcome to the Health and Hospital Committee meeting of August 8th. First day of school here for many of us. I am Supervisor Ken Yeager, Chair of the committee, and joined by Supervisor Joseph Median, who is Vice Chair of the committee. We'll go ahead and start with public comment. We have three speakers, Scott Largent, Lenora Williams, and Bob Jeski. So you can just come on up in any order.
All right. Good morning, everyone. I hope everyone had a really good summer. I actually did. I stayed pretty busy. Got a little distracted getting over here. I got a little smaller bullhorn to use. So this trusty thing it's pretty effective walking up and down the light rail, and then I go by the police department. You know, exercise my First Amendment right, which continues to get kind of knocked out here in Santa Clara County. So I'm still having a lot of problems with that. Victorious is writ. It's beautiful work. This has been submitted, so we're still fighting to get him back in here because I know he can be a pain in the ass, but so can I, and we have every right to do that. So I liked a lot of the stuff that Victorious talked about in here. He understood the legal community a lot better than I did. Coming in here, I was kind of gung-ho going after the sheriff's department for what had happened to me in law enforcement. And then I started to really realize the big picture of, as Victorious would call it, illness-spreading germ attorneys spreading their hustle. And that's a big problem we have going on here in Santa Clara County. Victorious did not have his rights protected, neither did I. It was a disgusting process that we went through over there. Thompson Sharkey, Shady Thompson Sharkey. That's a legal office. It's across from our new courthouse over there. And if you would all like to go on YouTube and type in my name, Scott Largent, you can witness me protesting Sharkey's office, talking about how Victorious was not able to exercise his Pareto rights. He was not able to recuse the judge. Basically, your county attorney through the IDO played puppet with him. And I really get it that nobody really cares in here about this, but you got to understand what's happening to people's civil rights and how James the Devil William can sit there and play puppet with these attorneys. It's a disgusting process. Now, Victorious, he will come out on the better end. We deserve to have him back in here. They tried to get rid of me. It's not going to happen. And I would just like more members of the public to start getting involved. We're setting up some protests. We're doing a lot out in front of the PD. And I think a really good zone to do a lot of this stuff is right out in this, in this free speech zone that we say is out there. I think that would be a good place. I think it would be a good example for the United States to understand what's going on with our First Amendment rights. I was also set up to fail. Just like the protesters over at that rally over there at the San Jose Convention Center, they set those people up to fail. They let them out the front door just to get beat. They set me up to fail out in front of that police department. I requested a permit for months. I tried to go the right route to get that. They denied it. Then what did they do to me? They set me up out in front of there. They threw me in the jail, then they machinated against me. They applied bail, they put will reoffend. They did all this to somebody that has no criminal record, and all I was doing was exercising my First Amendment rights. So that's what we have going on here. I'm not Republican, I'm not Democrat. I'm really questioning our government here. Everybody has the right to speak up, no matter what your race is, no matter what your party is. It doesn't matter, you have that right. Just not in Santa Clara County and not in the city of anti-democratic San Jose. So thank you.
Oh, sorry, my bad. Good morning, Leonard Williams here. How's everybody doing? I hope everything's fine. I'm here today as a patient, not as a PFAT member. I have a complaint. I know everybody's working on it. What has happened was on the 20th of the month of July, I went to East Valley Medical for an emergency at 7 o'clock at night. I get over there, I can't talk, I'm not feeling well. I walk in at 7 o'clock knowing that we're open till 9:30. I walk in there and I know you're all working hard at it and I hope it happens soon. There was no doctor available for me. I said, where do I go? They sent me to the downtown clinic. They treated me very well downtown. They found out I had laryngitis, which was a virus, and I'm doing very well now. I'm very proud of my hospital. I'm very proud of the staff. I'm very proud of the clinics, and I'm going to fight as hard as I can to see that we have the best hospital, the best clinic, the best staff that anybody can have. And I'm really willing to work with each and every one of you. So I appreciate what you're doing for us. I'm hoping that we could get some more staff on board so that when I go to places like East Valley and they tell me it's 9:30, that there is somebody there to take care of me so that I don't have to worry about it. And again, I want to thank each and every one of you and hope that you get us some staff so that we are totally covered at each clinic, everywhere we can be covered. Thanks, everybody, and have a good day.
Yes, my name is Bob Gazinski. I'm with PFAT, and I'm here to talk to you about whole person care. I was asked to sit on the Citizen Oversight Committee for whole person care, and I want to let you folks know, I want to thank you, especially the Board of Supervisors and all that. The program is working. It's working. I've seen change. We make recommendations. There was one recommendation I made several months ago, and it's already been implemented, helping out our most vulnerable in our system. I'm also here as a navigator for one of the patients that got signed up for the program. Even the judge, Judge Clark, in his courtroom, because he had some drug problems, he's been involved with the legal system, expressed that whole person care is a better program than the county drug diversion program. And I'm working with the Public Defender's Office and the DA to make sure this program succeeds. He is doing great. I'm getting all kinds of positive feedback of his condition. So I'm just here as a citizen and as a member of PFAT, thanking you folks that you took on this assignment, this deal, and it's making a difference in our community. I appreciate that and thank you.
Thank you. We'll move on to item 3, which is to approve the consent calendar. Is that a motion I hear from you, Supervisor Smidian?
So moved.
We will send that on to the full board. We move on to item 4, which is to consider recommendations relating to specified medical staff at Santa Clara Valley Medical Center.
Good morning, Supervisor Yeager,
Morning.
Supervisor Smidian. I'm Dr. Thomas Winsing, President of the Medical Staff. I'm here to present the monthly credentials report, and we'll answer any questions you have.
I don't believe we do, so
Move to ratify and accept.
we'll accept those. Thank you very much. Next, we move to item 5, which is consider recommendations relating to the monthly report from the Director of the Santa Clara Valley Health and Hospital System. Renee, take it away.
Yes, and thank you, Mr. Chair and Supervisor Smidian. I have a written report that summarizes several key areas. A couple things that I wanted to highlight that our staff have been working very well. And first of all, I want to thank Bob and Leonard for really being the ears and eyes and obviously giving us the direct patient experience and input and feedback in terms of our system, whether it be the good, the bad, and the ugly. I think we're always appreciative in terms of their engagement. And he mentioned whole person care, and I have an update on that particular piece. Alice is in our room here, and she's been leading the effort not only for meeting some of the project deliverables, but more importantly, on the T2020 engagement. They've gone through their 90-day cycles, and you see an extensive report indicating what they're coming up with the first set of recommendations out of the 90-day cycle, specifically adding peer navigators and health advocates so that, in fact, our most vulnerable populations continuously be engaged with our health system. So we're putting that request, and it's going to be going to the full board for consideration for additional 27 positions, and the details are in there in the written form. The other piece I wanted to acknowledge is Dr. Arnold being recognized by the American Association of Nurse Practitioners. He is a physician, but he's been a big champion for whether it be physician assistants or nurse practitioners, actually improving not only access but also quality across our system. So I want to thank you, Dr. Arnold, for that particular piece. And then lastly, on the custody health, we intended to have a series of dashboards for you today. We're having some difficulties in terms of the putting that information together. I think it's going to take us about a couple more months. But nonetheless, we wanted to show you in my direct report some of the improvements that the staff already have done as a result of not only the deployment of HealthLink, but also with your support, the deployment of behavioral health teams. And specifically, I call out a couple charts in my report. One of them showing that the number of patients that have been served by our acute psychiatric facility in the jail, which is what we call our 8A, we have increased not only the volumes of people going through there, but also reduced their length of stay, so people are not necessarily languishing longer than they need to. And I think that's a perfect example of how we're improving the care service access, as well as shortening the amount of time that people really need to be in these acute settings. And then the other piece, which is the white card, which I know our board has been spending quite a bit of time along with stakeholders. We're able to now incorporate the white card processing into HealthLink, so we have better information and data about what the inmates are requesting, not only in terms of service, but also care, and also be able to keep track and monitoring of those. And we have pretty much a trend chart related to that. And Matt and his team have been doing a great job related to that particular piece. One final note on that, we've hired Dr. Nathaniel Woods as our first Director of Behavioral Health Services within the Custody Health Services, reporting and working closely with Matt and all of us, so that in fact we address the issue of the mentally ill within the both main jail and Elmwood and other facilities. So that concludes my report, unless there's any other questions.
I don't see Mr. Brownstein for the working partnership. Oh, there he is. Right on cue.
Pretty impressive timing. Huh?
That's good utilization of your time. You really got it down here.
Thank you. So, I wanted to report that the stakeholder group last month began to focus on the issue of the health of immigrant children, particularly in relationship to the family separation policies that had been developed and implemented by the federal government, and which they are now, to a certain extent, retreating from. There were two levels of concern. One is whether there are children in this area who are in need of health services and not getting them because of those policies. But also, there's a concern that other children who are not in jeopardy of being separated don't know that. What they see on television is that a child who looks just like them is crying and being separated from their parent, and they don't understand it, and they are fearful. So we are interested in pursuing both of those issues, one through a convening of healthcare providers to talk about the direct services that children may need if they in fact have been separated from their parents, and secondly, another kind of process in which we would be communicating with people whose children are fearful to see what can be done to try and address those concerns and alleviate those feelings.
Great. Well, thank you for being here. We now move on to the verbal report relating to federal health policy and the budget landscape. Bert, good morning.
Good morning. The Congress is on recess this week, which has created in Washington a moment of calm, a rare moment of calm, before they launch into the final effort to pass a budget for this year, which will occupy the rest of August and through September. It appeared for a while as if Republicans and Democrats and even the president were all on the same page about avoiding a government shutdown and getting a budget package to the president's desk, maybe even avoiding a CR. That appeared to be the case for a while, at least, until the president, about a week or so ago, linked the budget to the building of the wall, the funding of the wall, and that created a sense of panic on the part of the budget negotiators. How can you get that done and not have the threat of a shutdown? We don't know what the president will say next week or the week after on the wall issue. So while there's some sense of anxiety about a budget impasse, Democrats and Republicans in both the House and Senate are still fairly well determined to get a budget done on time and to avoid a shutdown and not to let the wall be an impediment to that. So that's likely to work out, although with the president's interest in the wall, it creates a wild card. It creates an element of uncertainty about what late September will look like. We do know that in the course of this budget negotiation, there is unlikely to be any significant action on the ACA or health care. Nothing in the pipeline that involves the major health programs in the federal budget. There has been, over the summer, a major legislative package regarding opioid treatment passed by the House, and they're now negotiating with the Senate. Some 58 bills were in this package, all sorts of ideas, not a lot of new money, some, but not much. Things like the Institutes for Mental Disease policy that restricts the use of Medicaid funding for inpatient treatment in what are called IMDs. That would be relaxed in this package for opioid treatment. There are initiatives in this package that deal with the tracking of prescription drug use and various strategies designed to identify abuse by prescribers and by patients and have early intervention. It's a complex package. Negotiations between the House and Senate are underway this summer. Another issue of concern to the county is the 340B drug discount program. There was a hearing this summer about that in the House. There's still a lot of discontent at the federal level about the way the 340B program operates and the possibility of legislation. But if it happens at all, it would probably happen in a lame duck session that would occur after Election Day. In fact, there are a lot of things that could happen in a lame duck session that we can't fully anticipate now, depending upon who wins and who loses in November. The lame duck will be a period of jeopardy, and a hostile or negative 340B reform bill or a bill directed at reform, I should have put in quotation marks, because a lot of what's being talked about as reform is really an effort to just restrict the use of these discounts by safety net providers and others in the system. So while there isn't going to be a major policy debate in the Congress about the ACA, there is, in fact, a very aggressive initiative underway at the regulatory level. CMS is continuing to pursue a series of regulations that are designed to make life for the ACA more difficult. The major theme of these regulations is the promotion of insurance policies, so-called skinny policies, or some call it junk insurance, policies that don't comply with the ACA requirements in terms of the benefit package. The CMS is trying to find a variety of ways to allow people to buy those policies, which in fact would take younger, healthier people out of the pool for the ACA, jeopardize the stability of ACA purchasing pools, and provide people with insurance that in some cases, if they ever needed to use it, would not be worth all that much to them. One initiative, one rule involves association health plans, a rule that was issued at the start of the summer that significantly expanded the ability of individuals and small employers to call themselves in the loosest possible manner an association and create a health insurance product that would not comply with the ACA. There are a number of attorney generals around the country, 11 specifically, who view this as an effort to subvert the insurance protections of the ACA, not a legitimate regulation, and they are suing the federal government. California is part of that lawsuit. The Attorney General, Javier Becerra, has joined that lawsuit, calling these plans junk policy. There's another rule that was issued just last week involving short-term plans. These are plans that were they don't comply with the ACA. They are designed to really carry people over for a few months while they're between jobs. That's the theory of short-term plans. The Trump administration rule would allow these plans to exist for not just 3 months, the current policy, but for as long as 12 months, and then allow for 3 one-year extensions. So you could actually have this substandard coverage for as long as 3 years. Again, same objective as the association health plan rule. So that's the regulatory front, promoting junk policies. There's this lawsuit in Texas I mentioned at the last committee hearing that I want to restate again because it could be significant down the road. 20 Republican state attorney generals suing the federal government, Texas v. United States, in an effort to gut the pre-existing condition protections in the ACA. Their theory is that when the Roberts Court affirmed those insurance regulations, Roberts based it on the fact that the individual mandate was enforced through a tax, and this was all tied to that individual mandate tax, and in Roberts' opinion, it was a legitimate use of federal authority to regulate the insurance market nationally because that tax was a federal tax. Well, the Congress last year, as we know, got rid of the tax for the individual mandate, so these 20 attorney generals jumped on that, and they've put together this lawsuit saying that because the tax no longer exists, the Roberts rationale for upholding the pre-existing condition protections is null, and we want it repealed. This becomes relevant in the Kavanaugh Supreme Court confirmation hearings when you hear senators talk about how the Kavanaugh appointment will impact pre-existing conditions, something that's repeated over and over again by many Senate Democrats. It's because of this Texas case. That's what they're really referring to. So it's important for us to be aware of that. So the individual mandate, speaking of the individual mandate, was repealed, and there were predictions that it would weaken the law, and it has weakened the law, but not as much as many of us feared. It's had a negative impact on pricing, no question about it, but the rate increases for insurance in the coming year, 2019, are very bad in some states. Washington State, 19% premium increase. Maryland, 30% premium increase. But there are many states, including California, that actually have increases announced that are below expectations, notwithstanding individual mandate repeal. So Covered California announced last month that insurance plans under our California program will increase an average of 8.7% next year. That compares to over 13% last year, so it's actually a reduction in the rate of increase, much better than what was feared. Covered California did point out, though, that the elimination of the individual mandate did have an effect. It wasn't a non-event, and that of that 8.7% increase, 3.5% of that is related to the loss of an increase that relates to the loss of the individual mandate. So in other words, if Congress hadn't acted, we might have had in California as little as a 5% rate of increase. We instead have 8.7%. Again, clearly it's not a death blow to the law. We're doing still relatively well here in California, although Covered California says, well, the pricing is much better than expected. If you don't have a penalty attached to the individual mandate, they're estimating that some 200,000 Californians will voluntarily choose not to buy health insurance next year who otherwise would have purchased it if the mandate was in place. Again, that's a projection, an estimate. We'll have to wait to see how it actually plays out. Final topic, Mr. Chairman, that I want to raise, sort of looking forward to the next several months and into next year in terms of what we have to be concerned about, involves the renewal of the California 1115 Medicaid waiver, the so-called Medi-Cal 2020 program. There's been discussion this morning already about the whole person care pilot that Santa Clara is aggressively pursuing. There are a whole series of initiatives designed to improve access to care, promote a better quality care, pay for performance in various ways, financing reform, all tied to the waiver. That waiver expires in 2020. The process of renewing it is going to begin rather promptly. The new administration in Sacramento will be dealing with this literally within weeks of coming into office. They've got to use 2019 as the year to develop a extension proposal, and they've got to negotiate in 2020 with a Trump administration that has not been especially friendly to California on a wide range of policy issues. So it's going to be a challenging negotiation. There are billions of dollars in funding for public hospital systems in California that are at stake, so it's one that we'll have to focus on very, very carefully and very strongly in the months to come. It's going to be an issue of major impact for Santa Clara County. Happy to respond to questions or comments.
Well, thank you, Bert. Thanks for the comprehensive report. Just a couple comments and a question. I know, Renee, when Congresswoman Eshoo came out and we did the tour of the Subrata, we talked to her about the 340B, and she, I think, needed more information as far as how beneficial it is to our patients. I don't know if we were able to have that communication with her.
Yes, we've given her and her staff several reports as well as data in terms of the impact that would have on VMC as well as some of our local providers.
Okay, yeah, obviously, with her being on the health committee, that's critical that she understands the issue and hopefully will fight to maintain the current policy,
Correct.
which would be great. And it was just strange, Bert, to have you talking about the waiver and that it expires in 2020 and sitting right across from Renee, remembering all those panic phone calls. We had to try to get the waiver approved, and for some reason, year 2020 seemed far away, and
It's happened fast.
it's happened fast. And Bert, I don't know if I had heard correctly, I mean, as far as the skinny policies or the junk health policies, if there's a move in California that would prohibit those from having insurance companies do that, is that something that's being discussed?
I am sure it will be discussed. You know, right now we're in the final weeks of the legislative session, and this just was promulgated within the last month or so. So I'm not sure that we'll see action this summer, but I'm absolutely certain that California will be scrutinizing it. The New Jersey Insurance Commissioner has already made a proclamation that they intend in New Jersey to regulate these insurance policies very aggressively, no matter what the federal law says, and they're part of the lawsuit as well that challenges association health plans. So there's some states are taking an aggressive tack. I'm guessing because we have a transition in administrations also. A new attorney general will be coming in, new governor will be coming in. There's going to be a little bit of a lag before California develops a full agenda here, but I expect we'll see aggressive action. And the point that I did make is that Javier Becerra, our current attorney general, he's joined the lawsuit against the association health plans. He's part of that litigation.
Right, you mentioned that. Thank you.
Right.
Supervisor Smidian?
Two things. First, Mr. Chairman, before I go to our consultant, let me just ask, I did want to make sure we found some time today to talk either under 5A or under 9 about the potential acquisition of hospitals here in the Valley. So I don't know when and where you want to do that, but I just sort of wanted to give staff and you a heads up.
Okay.
And we can either go back and do it under 5A or under 9.
Why don't we just do it under item 9 and
Good. Got
have
it.
people
Thank
give
you.
a couple thoughts
And then
to it?
here's my question. I'm going to ask you to go a little far afield from the healthcare world, since I know your analysis of the healthcare world requires you to be looking at the larger picture. It occurred to me as you were speaking that we are a year and a half into this session of Congress. There was a big spending bill, a very big spending bill, as I recall, back in March that drew some attention. Other than that, and I'm not being flip, I'm really sort of trying to sort through this. What are the most significant accomplishments of this Congress? So I mean, we're coming up on the end of the session. Looking back, is there? I mean, there clearly are some issues that have not been addressed, and I just say that objectively. Immigration's not been addressed. Infrastructure's not been addressed. These were two big issues, or sets of issues that folks had. Are there? I'm trying to ask myself, other than the spending bill, which is not a small thing, is there something else that people will go home and say this is what we accomplished during the last 2 years?
Well, that's an excellent question, and I think it'll vary to some extent by region of the country. So, for instance, in this negotiation over the budget, the Defense Department's budget has been enhanced significantly. So if you're from an area of the country where there are military bases and where you've been worried about defense cuts or about uncertainty over future funding commitments by the federal government, the advocates for a strong and our large defense budget have done well. So I'm sure members of Congress who care about that issue will tout that as an accomplishment. This opioid package, even though it doesn't provide much money and it's incomplete as an initiative, it got overwhelming bipartisan support. It's one of the few bills in the Congress that passed, I think there were like 20 or 30 no votes and 370 or so yes votes. That's a rough approximation. So both sides are touting that as maybe the main example. Assuming it becomes law, it hasn't become law yet.
That was my interruption. Thank you for anticipating my interruption, which is, if I understood you correctly, it's now in the Senate?
It's now in the Senate. It passed the House. The Senate has developed its own ideas. They're negotiating. And it's likely to become law, a package, because there's such strong bipartisan support. But the Democrats are calling it incomplete. There really should be. They're arguing a massive infusion of new funding, and the dollars simply aren't there. But I'm sure that that'll be described as a major accomplishment, Department of Defense. And then, of course, those who support the tax cuts that will cite that.
Great. Thank you for that. 1, 2, 3. Helpful. Thank you, Mr. Chairman.
Great. Thanks again, Bert.
Thank you.
We'll move on to 5D, which is report from Behavioral Health Services.
Good morning. There's a lot of detail, as always, in my report. I just wanted to highlight 3 big areas. I know that you're very interested in the rate adjustments for the providers, and we've been working very closely with county administration as well as the providers to identify the rates. We're meeting with them all starting this week. We've provided a lot of information in writing, and our focus with the rate adjustments is really on direct service positions that have been very hard to fill, the clinical positions, and also the quality management positions that providers are trying to hire to meet all of the new regulations. So we have a process in place. We started meeting with the providers this week. We have quite a bit of information in writing based on that, and if the members would like that information, we can.
And my sense is that what we're proposing is something that they will gladly accept.
Yes.
That's the hope. Great.
Yes. Yes.
That's a lot of work, so thank you for that.
It's a lot of work, but it's going well.
Good.
And we're
Certainly fulfills a commitment that the board made,
very
administration
strong
made,
commitment.
to be able.
And in addition to the rate adjustments, I think the other piece that's very important, we are modifying some of the contract language related to direct services. We've also secured technical assistance from Harbage Consulting, which the county's been using, many counties use, to provide direct technical assistance to our contract agencies so that they can, look at the best possible way to meet the network adequacy requirements, the quality improvement requirements, and strengthen their organizations when there's such a time of change in behavioral health. So we're doing it on both ends.
Great.
Okay. The other areas, 2 areas I know you've been interested in, are the mobile crisis teams and the sobering center. There's a lot of information in here. Again, we're working very closely with ESA on a special hiring to assist us with the mobile crisis staff. That's underway right now. And on the sobering center, we're up to 165 clients as of last month, a 35% increase. We're working closely with the chiefs who I meet with this week. There's a sobering station video, and the chiefs seem very, very interested. So we'll continue to report on that.
Yeah, I thought the idea of the video was good.
It's quite good.
You don't have
Bruce
to
Copley,
try to set up
our,
meetings with everybody. You can sort of ship the video
Our
off.
director of alcohol, drugs, and access, Bruce Copley, is the star of the show as someone who's picked up by the team and taken to the sobering center. It's worth watching to see Bruce in action.
All right.
The other 2 areas are both the HealthLink NetSmart implementation and the MHSA plan. As I've written in the report, just the high level, we're working very closely with ISD Compliance and Council on developing proposals, looking at proposals with NetSmart to meet the needs of those clients that are served directly by substance use providers, and also the mechanism for bringing our contract agencies into our electronic health record. So that's underway. And the last thing that I wanted to share is we have that very robust MHSA plan, and you'll be seeing on August 28th a list of positions funded by MHSA that will support our infrastructure and the direct services provided by the county.
I know it was in the report. How many people are we then hiring to
We'll
do
be
that
bringing forth 31 positions.
work? And optimistic that we're going to be able to find
We
people
are
in this very tight
optimistic. We
job
are working
market?
very, very closely with ESA on both the mobile crisis and the other positions that we need to fill.
Great. Supervisor Smitty?
Thank you. The only thing I want to do on this item, Mr. Chairman, is to say thank you to Ms. Tully's and to Dr. Smith for a meeting that we had, which I wanted to sunshine last week with Mayor Liccardo of San Jose and some folks on his team, including the police chief. They approached us about potential collaborations in the mental health and larger behavioral health arena, and based on that meeting, I have submitted a referral, which I believe will be on our agenda for the next board meeting, about a possible joint meeting of the city council and the board to discuss those issues, potentially among others. So I just wanted to tee that up since we had some interested parties in the room. And thank you again. Thank you.
One public speaker, Scott Largent.
As Mr. Largent approaches, if I can ask him to bear with me just one more minute, I just wanted to indicate I was thinking as I heard about the sobering station. It's a reminder. I just think it's worth noting that it does sometimes take time and some extended outreach for good ideas when newly implemented to achieve their potential. I have been working now with folks in the North County on the homeless shelter in Mountain View that some of you have heard me talk about from time to time. And, you know, the phone call rings from the press the first night saying, you know, why are there only 24 people when the capacity is 50? And the answer is it takes time. People need to understand, and you need to keep reaching out. And if there are real reasons why people aren't coming and accessing the service, then good to identify those and address them. But I think we sometimes think that, you know, we send out the announcement, we open the door, and people will flood the facility, and it's a little more complicated than that. So I'm pleased as well, and just wanted to add that there's continuing outreach, because it just takes time for people to change the patterns they've fallen into over years and years. Thank you for your forbearance.
Thanks. Scott?
Great. Thank you, everybody. Scott Largent. It's good to hear that to kind of get on board to what's been going on here. A lot of people from the public have been talking about what's been happening to the homeless and the mentally ill for years, as the city of San Jose just gasses them and takes everything that they own. So I'm sure right now maybe Sam Liccardo and Chief Garcia are maybe in a panic stage right now that they've been taking everybody's car, their motorhomes, all their stuff. And now, I mean, like behavioral health's very well aware of, we got them all stockpiled downtown now and other parts of our city. This is shameful, and I keep saying that. I just, you know, I hear Tony talking about these videos that you guys are putting together. Now, in my mind, I see this of taking this mentally ill person to the right place and treating them with dignity and respect. I mean, I kind of see that in my head. But then what I see is that video over at the public defender's office. That's the worst hokey video I've ever seen of this poor African-American guy that's just getting set up to fail, and they're acting like they're having this dignified meeting, and they're acting like they're helping me. So I hope your video works out a lot better. Now, the videos I've been putting up online of filming law enforcement interacting with the homeless and mentally ill, these are real. This is real stuff. It's real interactions of seeing how law enforcement handles the public here, how they handle the homeless, how they handle the mentally ill. Last week, I was able to film right near that, it's the cleanup crew thing that we have right near St. James Park, Groundworks. And a lady was kind of living on the side there. She kind of had her little setup. And we got to see how law enforcement handled her. And we got to see their demeanor and how the officers were sitting back like this, and they're crossing their hands, and they're not even helping this poor woman move her stuff, pack her things up. They didn't offer her any services, any mental health, nothing at all. And I filmed it right there, and then you get the response back from the officers that decide to intimidate me and treat me bad. Please go on YouTube. I'm going to put all these up here, and it's not just to shame everybody. This is what you can learn about what's really going on out there, not these Fisher-Price videos that we're going to put up online. So thank you.
Thank you. Supervisor's meeting will take a motion to approve item 5. And we'll move on to item 6, which is to receive the health officer report, including an update on the Public Health Department strategic plan.
Good morning, supervisors. Sarah Cody, health officer. I mostly just want to update you on our strategic plan. I think that the real health event while we were recessed in July was that there's wildfires all over California, and most of the health questions that we're getting are around air quality. So that was really the largest event. You have the summary of our progress and accomplishments on the last 3-year strategic plan in your packet. I don't have a PowerPoint. I'm happy to go over it. I guess you're welcome, supervisors.
Giving a little thumbs up.
Yes. I just by background, what I will say is that this is the first comprehensive strategic plan that the department has had. It did sunset in June. We're going to wait till the fall, this fall, to begin planning for the next 3-year strategic plan, which would be 2019 to 2022. I think that we learned a lot in this experience that will inform our next plan going forward, namely to make it a bit simpler and easier to track. But we'll go through the whole process again in the fall, and including, I would like to find a way in the process to ensure that we have input from you all in our strategic direction for the next 3 years. I'm happy to answer any questions you may have about the plan, but I will not go over it.
No, just you've done a lot of work in a lot of different areas, and it was very impressive. So I thought it was a very good report.
And if I may?
And if you may?
Just to say, all kidding aside about PowerPoints, although I am reminded of the expression, power corrupts, PowerPoint corrupts absolutely, which I will share with the committee today. I did find it a really nice, crisp summary of some key strategic areas that's useful. And I wanted to say, as I have sat on the committee over these years, the discussion under Strategic Priority 6 about supporting the continuum of care between healthcare and community settings is one that has intrigued me more and more. I think, one of the benefits of being a layman is that you can grossly oversimplify almost every healthcare issue that comes to you. And I think a lot of times people just think of, well, you're either sick or you're well. So you're either in the hospital or you're not. And of course, that's leaves out so much in that continuum of care that we've been focused on over these last 6 years. So I just sort of wanted to underscore that one as one that I have a continuing interest in. And I think it requires some subtlety and nuance of understanding from a public health, community health standpoint that is sometimes difficult to communicate, because I do think people sort of think, well, if I'm not in the hospital, then I'm at home. And of course the answer is maybe not, and that might not be the right. And if you are at home, let's talk about what that ought to look like and involve. So thank you particularly for focus on that piece. That's it. Thank you, Mr. Chairman.
Great. Thank you. With that, we'll take a motion to approve and move on to item 7, the semi-annual activities from the Valley Medical Center Foundation.
Morning, supervisors and leadership. Chris Wilder, CEO, Valley Medical Center Foundation. I'll answer any questions that you have about the report that I submitted in writing. And I'd like to point out 3 things in addition to it before we do that. The first is that along with this written report, we also submit our annual report for calendar year 2017, which is available on our website in great detail. If you look at it, you'll see a lot of statistics about the money that we raised, about what we did with it, and a lot of stories about some of the people who have been touched by the work of the health and hospital system that I think is compelling. We also have our audited financial statements, which are not as compelling, unless you're me, and the list of every single donor during the calendar year 2017, which you can review. And if you are overwhelmed with jealousy that your name is not there, then there are ways that you can take care of that for this year by supporting the VMC Foundation. So take a look at that if you wish. The other things that are available on our website is something that I haven't pointed out in the past, I believe, and that is that this is the 30th anniversary of the Valley Medical Center Foundation. We were born on March the 1st, 1988. Our first board chair was Mike Fox Sr., who wrote the first check, and there's a lot of history along that. So what we did is created a presentation of 30 good things in 30 years, and it's worth reviewing because I think it really highlights a lot of the things that we've done over the years since way back then that relate to the health and hospital system. And I think it's a great reminder of what I tell people when asked, to what do you owe your fundraising success? And the answer is, have something wonderful to raise money for. And I think that it's a tribute to the county and to Santa Clara Valley Medical Center that we've been so successful, that there's always something compelling that our donors respond to, and that presentation does that. The final thing I'll mention that also is highlighted on that website in our news section is the fact that, as mentioned in the annual report, we had applied for ethics accreditation through the Standards for Excellence Institute, which is a replication partner out here by the Markkula Center for Applied Ethics at Santa Clara University. And I'm proud to announce that last week we were actually given that seal of excellence, becoming the only nonprofit in California and the only hospital foundation in the United States to hold that seal of ethics accreditation. I can go into detail on that if you wish, but it's much more than just adherence to mission and vision and values and doing the right thing when nobody's looking. It really is. It's been equated to ISO 9000 for nonprofits, and it really is a scrutiny of every single business practice that we do, from succession planning to finances to the way that we respond to advocacy issues in this county. So I'm very proud of that, and I'm happy to answer any questions that you have on that matter or anything else in the report.
Well, first, congratulations on that accreditation. And as you just said, the only nonprofit in California, is that right?
That's right.
Received that. And do you sort of see then other foundations sort of pursuing the same accreditation just as a way to show to the public that you're abiding by everything that's sort of ethical and legal in the work that you're doing?
It's a great question, Supervisor Yeager, and the answer is yes. If we become the only nonprofit to hold this certificate and remain so, I feel that that certificate doesn't mean as much. Now, we went down this path, the ethics journey, as we called it, over the last year, because we felt it was the right thing to do. We weren't doing it simply to get accredited. But now that we have it, I think there's a responsibility that we have as an organization to advocate for it and really evangelize for that process. It made us a better organization. And so I've been reaching out to some of my nonprofit colleagues, many of whom are very interested in pursuing it. They have responded to a training that's been set up through the Markkula Center for Applied Ethics, which is how I was introduced to the concept last year. And a lot of my nonprofit colleagues are pursuing this. And so I hope that over the next few years, we'll see a lot more Santa Clara County nonprofit organizations apply for and receive this ethics certification. It's going to make our sector better at a time when, frankly, the most important thing we have is donor trust. And that donor trust in this community, in our valley, has taken some hits lately. So I think it's an important step that nonprofits need to take, and I hope that they do.
That's great. And I know I'm giving a commendation to Parks and you guys on Monday for a day on the lake, but I didn't know if you wanted to mention that activity.
Wonderful. Day on the Lake was really, it was a wonderful event that I did not attend, unfortunately, but the folks in the rehab department and the volunteers in the peer support network at Santa Clara Valley Medical Center's rehab team partnered with us. We really were the fiscal and administrative backbone support for that event, but as I understand it, it was just absolutely fantastic. Imagine, several hundred people with different levels of disabilities who ordinarily wouldn't ever get to go out on a boat or a kayak on the water, and being able to do that. It's just a huge effort, and I participated in similar events before, but as far as I know, this is the largest that we've ever done, and so thank you very much for that accommodation that's coming. The team really deserves it.
That's great. Supervisor Shamanian? Then with that, thank you, and we'll make a motion to send that report on its way.
Thank you.
Now we move to item 8, which is report from the Valley Health Plan relating to activities, opportunities, and progress. Bruce, hello.
Thank you, Supervisor Yeager and Supervisor Samidian. In our monthly report, it reflects a fairly steady state of affairs. We also have a detailed quarterly report this month. So I will address a few issues from the quarterly report that were suggested to me that might be of particular interest to the committee. Focusing mainly on access to service on the part of our members. With respect to our internal telephone access in our call center.
Right.
The metrics in our quarterly report clearly show that we hit a significant rough patch in that area that corresponded to the Covered California open enrollment period, which is as you can imagine, the highest call volume events in the year for us. And in digging into what was causing that, which was very frustrating to the team because they had previously been on a nice trajectory of encouraging improvement prior to that. We discovered some problems with, among other things, with the interaction between our team and the vendor team that we primarily rely on as a outsourcing solution for the covered California population. We started hearing some anecdotal reports that weren't very favorable about our outsourced activity, did some secret shopper type investigation, and actually discovered that they were meeting their objective standards by closing out calls very quickly by referring those callers back. Well, look, you should just go look that up on the VHP website, or we don't know, you'll have to call VHP directly, here's their number, that kind of thing, which is not really a positive way to resolve calls, obviously, and actually really disturbingly was shifting the work from an outsourced vendor back into our own shop, thus defeating the whole purpose of them being there in the first place. So going forward, we have put in place in our proposed contract extension with Cognizant, they're our systems vendor, of which this group is a part of, much more rigid performance standards on them. They're not going to be allowed to say a call is closed just because they've pushed it back in that form. And we also made that part of the contract much shorter in duration than the overall systems contract, which lines up with one of our budget proposals for this year, which was approved by the board, which is a staffing augmentation for our call center that would enable us to actually roll away completely from that outsourcing arrangement and have adequate staff in-house to handle the call volume. And then last but not least, I never want to represent technology as the magic bullet for everything, but the particular telephonic system that we have had in place, it is one of the more archaic ones we'll find around, and we've got some great support recently from TSS to do a system upgrade for our telephonic system that's going to enable the team to delve a lot more deeply into root causes of answer time issues, much more direct mentoring of new staff, different kind of team approaches to handling calls, et cetera. So we're very concerned about that the results we had over those several quarters. We're doing a lot we're doing a lot of work to try to remedy that, and of course we'll be happy to keep the committee apprised as we go forward. Any questions on that?
No, but thank you for explaining it. I did see,
okay.
I did note it in the report and was curious as to why, so thank you.
Okay. And then timely access on the provider side of the equation, of course, is an issue that we have to focus on very attentively. By way of background, anytime a member does contact us in any way, telephonically or otherwise, with a concern about being able to make an appointment or accessing providers, et cetera, we register that as what we call a PQI, or a potential quality incident, and track that. We also ask all the providers all the significant providers in our network to provide us with reports from their internal appointment systems on how they're doing in terms of lining appointment, and most of our providers comply with that most of the time. So we really have those two different ways of tracking. For the providers that do report to us, as of right now, they are all either demonstrating compliance or There are corrective action plans in place that they've given us that we're satisfied with and will be tracking. And then the all-inclusive measure is the PQI tracking that also reflects providers from whom we don't get reports from, but we hear from our members. And that seems to be improving over time. We're seeing a trend in the direction of a lower volume of potential quality incidents that are related to access. So again, some optimism for continued improvement that we can continue to report on.
Great, thank you. Supervisor Semedian?
Move acceptance of the report.
And on it goes, so thank you. Now we'll get to number 9, which is a report from Santa Clara Valley Medical Center relating to operational, financial, quality, and safety measures. And maybe, Paul, when you're done with that, we can then raise the issue that Supervisor Semedian mentioned.
Okay. Thank you, Supervisor Yeager, Supervisor Semedian. I first of all want to take this opportunity to introduce Dr. John Fankhauser, who's our new VMC Chief Medical Officer. John, sorry. So, as you know, John has joined us with close to 30 years of experience in terms of public healthcare service delivery. He joins us most recently from his tenure in Liberia for about 4 to 5 years. He actually entered Liberia in that service area at the time of the Ebola crisis outbreak. He served as the chief medical officer there, but also became the chief executive officer serving that area, which is quite impressive. I know John from his years of service at in Ventura County. He comes to us with a very strong acumen in the clinical area, operations and business management in healthcare. So,
is there anybody from Ventura you haven't taken? Is there anybody left?
Dr. Smith and I have talked about that. And
I see. Okay, well.
Anyways, we're very fortunate to have Dr. Fankhauser as part of the team here at the county.
Welcome to Santa Clara County. Good to have you here.
Before I get into our marketing update, I also wanted to just briefly update you. Over the past couple months, we've been very busy at Valley, specifically in dealing with a number of different accrediting agencies. Last week we had the CARF, which is the Commission on Accreditation of Rehabilitation Facilities. They were here at the end of last week, and I have to say that it was a very successful survey. They not only commented, of course, about our staff and the incredible work that they do for our patients, but also on our new facilities. And I think we've raised the bar in terms of how we provide care to this very important patient population into our community. We also had the Joint Commission here reviewing our sepsis program. Very impressive teamwork in the area of sepsis and our results. And also baby-friendly status. And our renal care center went through a CMS validation survey, which was successful as well. They did have some findings, of course, but anytime you go through a validation survey, there will be findings, and it's really a question of how you respond and put a corrective action plan in place. And so the staff have done a wonderful job in making sure that people understand the level of care that we provide and the quality of care that we provide, and it's validated by a third party. With that being said, I'm going to turn this over to Patty Porter, who is our Director of Marketing, to give you an update on our efforts in this area.
Good morning, Supervisor Yeager, Supervisor Semedian, Dr. Smith, and members of the Health and Hospital Committee. My name is Patty Porter, and I'm the very proud and inspired Director of Marketing for Santa Clara Valley Medical Center. This morning, I'm going to share with you briefly some of the activities of the Marketing Department over the last 6 months. Just to remind you, our overall objectives for the marketing campaign for our health system are really to improve the brand awareness about Santa Clara Valley Medical Center. We want to elevate the perception of the public about what it means to receive care within our health system. We want to make sure we retain our current patients and customers as well as attract new ones. And we want to make sure that all of our messaging is reflective of the diverse communities that we serve. I'm going to talk briefly about the opening of the Subrata Pavilion, our new website, some marketing we've been doing with our amazing homeless program, some social media, a little bit about our first service line marketing campaign, and some special recognition we've received by marketing professionals. As you recall, our beautiful Subrata Pavilion was opened in December last year. We were very busy marketing the opening of that facility. We had lots of channels employed in that process: newspaper, radio, digital, television interviews, and we continue to have ongoing efforts digitally to promote this beautiful 168 private room facility available to all individuals who reside in our county. I'm going to introduce to you a digital ad for the Subrata Pavilion, which I will just set up, was inspired by our staff and by patients who receive care in the Subrata Pavilion. In February of this year, we launched a brand new website. It's completely redesigned. We are using the benefit of search engine optimization through the use of keywords with Google to drive traffic to our new website. This new platform is available both on tablets and mobile applications and linked to Google Maps. So if you're on your phone, you can actually brings you to our facilities. And to date, over 77% of visitors to our website are finding us on these mobile applications, which is tremendous. It's highly integrated, bringing in the rehabilitation service line onto the website. We are continuing to build the content. We consider ourselves to be highly responsive to the comments and questions that come to us through this channel. We're linking all of our campaigns and marketing directly to the website. And of course, we engage in continuous quality improvement, improving the content and the value of the information provided to our public. Website analytics. We are currently have over 47,000 visits a month with a high of 55,000 in October. Since the launch of the new website, we continue to see an increase in not only the number of visitors, but the number of pages that are viewed, which is a conversion metric. We're after making sure people come and look and spend some time there. The length of time spent on the website continued to improve. The scroll depth, which is we can measure how deep people are going into content, continues to improve. And what's called our bounce rate, which is the sort of go into and leave quickly rate, is significantly decreased, which means people are finding what they need when they come to our website. The content on the traffic, 35% of all visitors are looking at our home pages, 20% looking at clinics and locations where they can receive excellent service. Currently, 16 to 20% of all traffic is looking at our rehabilitation center. We know that's predominantly driven by the paid media efforts we have now at market, and 8% are looking at healthcare services and information about us. We also did some unique marketing in partnership with the Valley Homeless Healthcare Program and Marisich Health to brand these absolutely gorgeous mobile medical units that are now in our community, serving individuals who participate in our reentry program, our Valley Teen Clinic, people who are experiencing homelessness, outreach to migrant workers, etc., with the message that to our community that we are here to care, bringing care that comes to you. We're mobilizing healthy innovation for all when we're bringing health care to our neighborhoods. Very proud of these billboards, if you will, that are in our community.
Yeah, it's a nice logo. It's very nice.
We're also very busy on social media. Now have over 9,000 visitors. We own the Google and Yelp pages. We are very interactive with anyone who provides many compliments and opportunities for improvement. That information is shared internally, and it is used to inform quality improvement activities and to applaud our our teams, care teams, are working very hard to deliver high-quality service. We're also using Facebook to recruit individuals to join us, especially physicians and people with extensive analytic background, which are difficult to find sometimes using our typical routes. In collaboration, and I want to underscore this, with our rehab leadership team, our patients, and with Mhsa Health, we have launched our first ever service line campaign to promote our nationally recognized, actually internationally recognized rehabilitation service line. Our goal here is really to move the needle of people's recognition about the service that we provide with, again, a multi-level marketing campaign, multicultural, and reaching out to not only patients but also to providers in this new campaign with our key performance indicators, looking at impressions, click-through rates, and conversions, and I'll speak to that when we talk about the evaluation. Go ahead. So this is a reflection of our amazing exoskeleton, our amazing zero-G system. This is one of our care team members and a patient who received care here. Again, the goal here is to make sure that all of our imagery and messages reflects our staff at Santa Clara Valley Medical Center. The next image is really just an illustration of the extensive nature of the marketing campaign. We used many different cost-effective strategies. The purple you can see there was a unique strategy called Nativo, which we extended communications about our rehabilitation service line throughout Northern California. We have postings on Facebook, ads on Facebook. We used email actually to reach out to all providers using their NPI numbers within a 150-mile radius of Santa Clara Valley Medical Center to inform that not only about the Subrata Pavilion but also about the excellent rehabilitation service line. Those marketing materials were largely authored by our physicians and care team members within the rehab unit. We used Pandora radio advertising, traditional radio on Spanish, Vietnamese, Chinese, and English radio stations, of course, print ad, and out of home, which are billboards. So you can see we're moving out of Santa Clara County as we traditionally have and are moving beyond the region with this service line campaign. Key performance indicators, our goal was to achieve 28 million impressions. We did much better than that. We, in fact, achieved 34 million impressions, which we're very excited about. That is an expression of the reach and the opportunity for people to have seen our marketing information. Our click-through rates, which means when someone is served up the ad, was very effective, with the most effective multicultural Facebook ad, a portrayal of our very highly innovative peer networking support group. Had 1.5 million impressions, with resulting in 10,000 clicks to our website with this vehicle alone. So there's something about appealing to a Vietnamese population and the sense of support from others. Conversions are Google ads. Again, when someone saw an ad for us on Google, 43% actually went to our website, so we can see these ads are driving support. And while the Subrata Pavilion in and of itself certainly has improved our average daily census, back in December of 2017, our average daily census was 48.6. Very proud to report that in June, our average daily census was 53.4 to a budget of 54 beds. And we'd like to hope that our marketing activities have supported this improvement in utilization. And lastly, I want to share with you, I'm very proud of the number of awards that our marketing campaigns have won over the last 18 months, 19 in total. 3 of those coming from these 2 organizations, featuring our marketing campaigns to open the downtown center, as well as to continue the marketing. Our Go Public campaign is a recipient of 16 national awards from a number of organizations. The Telly Awards is obviously an award for our commercial. I'm most proud to share with you that most recently the Hospital Marketing National Advertising Awards is recognition from a national organization recognizing Santa Clara Valley Medical Center as the best multicultural campaign for Go Public, the best out-of-home campaign, which are all the visuals that you see at the airport, billboards, in theaters, etc. And I'm most proud to share with you the Delegate's Choice, which is an award that is voted upon by all the individuals who attend this conference. They can view all of the campaigns that are submitted, and ours was selected as the top campaign by all healthcare organizations for the national meeting this year. So I'm very proud of that effort on our behalf. Finally, I want to share with you what we're doing for the fiscal year 2018-19. We have submitted again our community employee survey for this past month. I have some preliminary data from that community survey of over 800 residents. Our brand rating continues to improve. People who experience Santa Clara Valley Medical Center, the favorability rating moved from 75% in 2017 to 79% in 2018. People without direct experience of Santa Clara Valley Medical Center also improved from 43% to 47% in the same year. Very proud also to share with you that view of public hospitals, regardless of individual self-reported insurance type, favorably moved from 46% to 55% in 2018. So whether you have private insurance or not, you are beginning to view the public health care system. The elevation of perception of the service that we provide is moving in the right direction. For people who know about Santa Clara Valley Medical Center, the likelihood to refer to us is increasing. And with respect to our brand attribution, people who receive our care are more likely to refer individuals. With respect to individual brand attributes, we're improving along the lines of Santa Clara Valley Medical Center improves high quality care. We are embracing new technology, and our care is highly innovative against some key strategic channels we want to achieve when compared to our competitors. Go Public continues in the market. We are venturing now into ambulatory care and urgent care marketing in areas where we have capacity. With the refresh for the beds in the Women's and Children's Center, we're getting ready to launch a new service line campaign there. We are working in 2018 on reputation management, which engages earned media and the way that the public continues to view us in health grades and other scores. And of course, we continue to work on internal marketing as key strategies and tactics. That is my end of my presentation. Go Public. Do you have any questions?
Well, thank you, Patty. So will you be giving us a more complete results of the community and employee survey at a future meeting?
Yes,
It'd be
I will.
interesting to see what those are. And can you remind me what our plan is for managing the Yelp page?
I manage those personally on a daily basis, and how I manage those is I respond directly to the individual who's responding, as well as send that information to the leadership associated with the compliment or the recognized opportunity for improvement. And I have to tell you, I'm very impressed with the engagement of our leadership. They do respond, actually reach out in many cases directly to the individual to understand the opportunity for improvement and act upon it directly. So we do have some really nice workflow and follow through. Was there a particular question?
Well, I looked at it, which I don't do Yelp, but looked at the hospital's Yelp page, and I don't remember seeing many responses to all of the comments that were made. I remember seeing one or two, but by far there was no response at all. So maybe
we have an opportunity to engage the individual who's responding directly or indirectly, and we choose to engage them indirectly. It's sort of, you have to be careful on Facebook because depending on the patient's level of anxiety or stress, you can get into sort of this public conversation that may or may not be appropriate. So we can respond one or two ways. I can speak with the folks at Yelp if you want us to have a more public response on Yelp, but I can tell you I do respond to every single one of them.
That's great to know, and you can't. Well, I'll let someone who knows Yelp better than I about whether it's useful to respond to them. I mean, I know that a lot of people just say negative stuff on Yelp, and you can talk to them all day long, and it isn't going to make any difference. Mm-hmm. And I do appreciate all of your positive comments, but I do have to say some of those comments on Yelp are ferociously bad, incredibly negative.
I would.
Which isn't to say that there aren't a lot that are very positive as well. But I have to say, I think I was a little shocked at some of the comments.
And I agree. I concur with your observation. We also have, it's sort of a phenomenon, I've not seen it written in the literature, but what we are tending to see here in the Valley is typically Yelp is the channel by which people complain across the board.
Absolutely.
So if you looked at any health and hospital system anywhere, that's
Absolutely.
where people go. We have people actually complaining from their bedsides that they're not getting their medication. It's kind of an interesting phenomenon. But we also see Google as a very valid and typically more kind of coherent and comprehensive review of our services. We are viewed much more favorably on Google. That is the place people give us the feedback for which we can really act upon it. So, we're looking at ideas and strategies for encouraging people who want to compliment us as well to use Yelp. I can't.
Right. No, I understand totally. Right.
Yeah, but I can
totally
tell
understand.
you, Supervisor Yeager, our staff are taking those concerns to heart.
And as you know, a lot of the complaints have to do with the wait time at the emergency room. And I know that some hospitals are sort of allowing people to text and have communication about how long of a wait there is at the ED, and so they can stay at home if that's medically okay before they come in. Are we looking at something like that as well?
We are looking at with our emergency department. The challenge is, of course, with a very busy trauma center. When trauma comes in, there's constantly kind of triage going on, and if you set an expectation of the public that the wait time is going to be 30 minutes, and trauma comes in that requires the attention of our physicians and our nurses, that, of course, is is the priority as directed by the medical team. So.
Yeah, I'll let Paul or whatever sort of look at it. I mean, I just don't know if there's other ways to do it. You can imagine anybody being frustrated at what they perceive as an extra long wait, and if they had known ahead of time, maybe they would have made different decisions. I don't know, but again, a lot of the criticism on Yelp anyway has to do with the wait time. So,
thank you, Supervisor Yeager, for your comments, and I would also add that. Patty Porter has done an amazing job in keeping us focused and moving in the right direction. And of course, with the leadership and support of Benita, I think we're on the right track. And I think we're definitely all looking forward to next year in terms of the two upcoming campaigns and service line campaigns around our ambulatory care system and women's and children's services. So a lot to look forward to. And we'll continue to provide you updates.
Great.
With that, I'm going to turn it over to John Cookingham for a brief update on our financials, and then we can...
Before we move on from this piece, if I could, through the chair. There was a lot there in that very comprehensive presentation. I want to try and just ask a sort of a bottom line question, if I could, Ms. Porter, which is, so in the ever-evolving digital advertising world, if I were to say, so what works and what doesn't, based on what you've tried and what you've experienced, what would you tell us?
I lost my mic here, but I can use it. Here it is. What works, the pay-per-click advertising, where we purchase keywords, seems to be working. The more accessible our information is, so making sure that any digital marketing that we deploy has direct connection to very specific pages on our website. Patient stories and the imagery of the institution works and has been driving traffic to our health system.
And was there something you tried and you thought, well, seemed like a good idea at the time, but just didn't pan out?
The Nativo actual approach, which is advertising that sort of shows up on the border of online periodicals. So if you're a subscriber to Reader's Digest, you see these images and you can click on ads about various, companies, organizations, businesses. The jury's a little bit still out on that. It's a relatively new channel, a way for people to find out or to advertise about services. We tried that this time, and we're still looking at specific feedback from Nativo, the organization, about the impact, the type of consumers who clicked on those ads, et cetera. So I will get back to you. That's the only one that I don't think I would be surprised if it has worked as well as we hoped it would.
Thanks. Don't need more, just wanted to pick your brain as long as we had you. Thank you very much.
All right, John, it's all yours.
Well, in the interests of time this morning, May was presented before, and we do have a draft of where we ended up in June. And the June activity is similar to that of May. We ended up the year very favorable as compared to budget, and we'll bring that to the details of that to the next meeting. I think that the next year has some challenges, but we're continuing to make progress. I'd answer any questions people might have. Things like cash generation and days in AR are very favorable at the hospital level. We're focusing on some of the other health and hospital system areas where we think we can improve.
No, I thought it was a good report. Always nice to see so many things headed in the right direction, and certainly the more we can give back to the general fund is appreciated by the whole organization. So thank you. Supervisor?
Thank you. And I'm not sure to whom these questions go, but there were, if I look at the, I guess I'm at pages, Mr. Lorenz, I'm looking at the report, the 37-page report, pages 3, 4, 5, 6, 7. These are where, Dr. Smith, the 4 phase 1 achievement goals are identified, goals 1, 2, 3, 4. And it looks like we're struggling on all of them, frankly. And if I'm reading the charts right, the goal, and I'm on page 2 now, actually, of the report, was to reduce annualized rate of outside healthcare costs to no more than $50 million, but I think we're still at the $100 million level. And goal number 2 on reduce non-acute medical patient census to 3.5% of the total average daily census. Again, if I'm reading the charts right, it looks to me like we're stuck around 6%. And then on goal number 3, non-acute psychiatric patients, was reduce non-acute psychiatric patient census to 30% of available beds, but it looks like we're still stuck around 40%. And then primary care clinic operational productivity, the goal was to increase patient visit capacity to 2.5 patients actually seen per hour of clinic assignment at 2 Valley Healthcare clinics, and it looks like we are really still a very long way away from that. So, these are all 4 of the phase 1 achievement goals, and, to put the kindest face on it, looks like we're struggling, and we're a long way from getting there.
Thank you, Supervisor. So a few comments. So first of all, we are kind of plateauing on some of these, and our goal is obviously to reach the identified target in each of these areas. I can give you specific examples of where we're at on some of these. So let me just start with outside healthcare costs.
Before you do that, through the chair, Supervisor Yeager, I know you had to step out briefly. I don't know if you heard that, but I'm looking at all 4 of the phase 1 achievement goals in the report. Maybe we could just pull those out for a report back at a future meeting and ask, what's the challenge been in making progress there, and what's the plan for the future in addressing the lack of progress to date. I don't need to put anybody on the spot today, and actually I think the committee would probably be, and the public would be better served by sort of calling it out now and letting you come back. But I think these are, when it's all 4 of the phase 1 goals that the county executive has articulated, I get squirmy. So that's a medical term there. So okay.
We would be happy to speak to these items and give you an update.
Is that suitable?
Absolutely.
Great. Then that'll be the request. And then, again, I think if we could hear a little bit at some point in this report about hospitals for sale, that might be, if this is the useful time.
This would be a good time.
Okay.
I'll jump in on that. First, a little history about the hospitals and why we're interested and why we think from an operational, strategic, and needs basis, they're important to our mission. O'Connor is located about, well, less than half a mile away from VMC. It's licensed for 300 and, I think, 60 plus or minus beds. Its recent average daily census has been about 106 to 110, which is obviously a problem. The hospital has been organized for many years as a basically private sector, nonprofit hospital. In that model, as a freestanding hospital, historical goals for success basically boil down to seeing sufficient number of insured patients to offset the cost of uninsured Medi-Cal and partially Medicare patients. You'll remember that when it was built and through much of its history, it was very close to a very financially affluent section of San Jose, the Rose Garden and surrounding regions. As time has proceeded, most of the affluence has moved to the north and to the west, and basically that's destroyed the patient population that O'Connor needs to function as a private nonprofit hospital. The problem that they've had is that they currently have a patient mix which is very heavy on Medi-Cal, Medicare, and uninsured, and has a very low percentage of privately insured patients. They've also had significant problems with private doctors referring their insured patients away from O'Connor to regional and other hospitals in the area. So that's why for the last decade and a half, actually more like 2 decades, there's been dwindling profits, and they've gotten to a point where after multiple providers have taken over the institution and multiple other systems have looked at it, they really just can't function any longer successfully as a private nonprofit hospital. Contrary to the private nonprofit model, the county operates in such a way that our funding is different than theirs. So Medi-Cal and Medicare expenditures are very positive for us because we get paid supplemental Medi-Cal, Medicare rates, previously called dish payments, soon to be changed to a different name. And our rates are based more on our costs rather than on the number of procedures that we do, which is the model for the private sector. So since this hospital takes care of many of the patients in the community that would be our patients in the sense that they are underinsured or uninsured, they have been really the only significant provider contributing to our mission. And so therefore, the risk of losing this hospital is a risk to our entire mission. So we're recommending to the board, and we're going to be discussing in closed session, at the next closed session, exact details, so I won't get into exact details, but we're recommending the purchase of the hospital. Also, coincidentally, there are cost savings associated with this purchase in the sense that we will probably not need to build a surgery center. Well, I shouldn't say probably. We'll not need to build a surgery center, which is on the plans. We also will not need to consider a new bed building. We'll be able to move patients out of the so-called old main, which is seismically not adequate at this point. And very importantly, since VMC is functioning at a very high occupancy rate, we'll be able to decrease the average daily census at VMC and increase it at O'Connor, which allows much better functionality and staffing. So it's a very important decision to make strategically and economically. We think we can operate the hospital at a much more stable financial status because of the different funding mechanisms. And so we're very interested, and we've notified Verity that we're interested. And as I said, details will be discussed in closed session. As far as St. Louise, St. Louise is in a slightly different model. They have their license for 93 beds. They have 73 beds staffed, and their average daily census is below 30, which is impossible to make work. But of that 30, a fair number are patients that are seen in our clinic in Gilroy for obstetrical care and urgent care visits to the emergency room. Also, you know that many of the patients that we see currently at VMC actually live in the South County, and we have some challenges with particularly obstetrical patients traveling for a long time from South County, Gilroy, up to VMC and for appointments and actually for deliveries. So St. Louise is important to us more from a perspective of a strategic location. We know that our patient population is increasing in South County and will continue to increase. Again, that is an important population for us to take care of. And as a freestanding hospital, it just simply can't exist. As a part of a system, it can exist and provide a very critical care in the South County for our patients. So if you have any other questions that aren't confidential, I'll be happy to answer them.
No, thank you very much. I found that a very helpful overview.
Likewise, I guess my one question at the moment, although I know we'll talk more about it on Monday, is O'Connor seismically upgraded? Is it any issues there, do you know?
Most of O'Connor is up to seismic standards. The only patient care area that's not is near the emergency room. It's not in the patient residential towers, so there would need to be some relatively minor upgrade if there is a desire to keep the current structure or allocation of services the same way. If we purchase and consolidate under VMC's license, actually there is no need for as large a laboratory function and presence in the physical building of O'Connor. We would be able to transfer those specimens just down the street to VMC, so there's a good likelihood we wouldn't need to change that or modify that. The old building that we see from the freeway is the historical first building, but right now it's all office space, so it doesn't have to meet the seismic standards. In terms of St. Louise, it all meets seismic standards, so that would be an advantage. And we're doing our due diligence to find every and all problem that would be potential.
All right, thank you. Oops.
I was just going to put in a plug-in for our confidentiality agreement, but yeah, I think you've covered it. Thank you.
I don't think I said anything bad.
I don't think so.
We are under a confidentiality agreement with Verity, so we have to be careful.
All right, thank you. Paul, anything else under your report?
No, thank you.
All right, Supervisor Smithian will take a motion for number 9. And then we'll move on to item 10, on report on the health and hospital system relating to emergency medical services system policies and procedures.
Good morning, supervisors and the committee. Jackie Lowther with the EMS director. During the February 15, 2017 meeting of the Health and Hospital Committee, a report from Santa Clara Valley Health and Hospital System relating to EMS service system policies and procedures for comprehensive stroke centers. The committee meeting 82528. At that time, the committee requested an update on the number of patients that bypassed primary stroke centers and went to comprehensive centers by acute stroke management. So since then, since our policy updated on December 18th, 2017, we have been collecting lots of data since that point and are now ready to give an update on all of the data that we've collected. And when we updated our policy in December, which outlined which patients should be directly transported to comprehensive stroke centers, we also implemented our new in-field assessment tool. And at that time, we also designated El Camino Hospital as a comprehensive stroke center. So at this time, I would like to turn over to my esteemed colleague who has all of the latest data that you have requested. Ken?
Sure. Thank you. Ken Miller, the EMS Medical Director. So the evolution of stroke care is both exciting and challenging. The science is moving rapidly, and the challenge for us as an EMS system is to decide, which motion we chase down now and which motion we watch for further development. So to give you some perspective, back in April of last year, we implemented a time-based symptom onset strategy for transporting selected patients directly to comprehensive stroke centers. In December, we modified that strategy to include a stroke severity score along with a time frame based upon the prevailing science. The reason for those strategies is there is mounting evidence that identifying selected patients in the field who have a certain type of occlusion of a vessel by a clot that is amenable to mechanical removal improves outcomes for those patients. The challenge is finding them using a clinical exam alone, as the criteria. What's also evolving is, up until very recently, it was the time frame of symptom onset that was used as the surrogate marker for the acuity of the recoverable portion of brain following an acute stroke. Now there are advances in imaging that allow a more objective assessment of which patients have sufficient recoverable brain that would be amenable to now more advanced techniques of clot retrieval. So as imaging improves, time frame becomes less important. In fact, it's being demonstrated that patients who are experiencing symptoms much longer than in the more recent literature or past literature are indeed candidates for clot retrieval and removal and can do very well. So in trying to keep up all of that, that's where we are advancing. So there are several categories of data type we're looking at. One, for example, is that of simply stroke diagnosis versus mimics. That's a challenge.
Excuse the interruption through the chair. If I could just ask, as you're giving the report, to discriminate between tools you're using in the hospital setting and tools you're using in the ambulance en route, that'll help me keep track what's happening where. Thank you.
Right. The only thing I referred to here so far that goes to hospital setting is the imaging strategies. Everything else that I've referred to is pre-hospital, out-of-hospital strategies. The other data set we're looking at is door to treatment. There are two categories of treatment. One is clot lysis or dissolution, thrombolysis. The other is clot retrieval or removal, which is thrombectomy. And the third category then, which is really the ultimate, is looking at long-term functional outcomes. The process toward getting comprehensive data is moving along. We have a contract pending with the American Heart Association for a stroke registry, which will provide us with much of what I mentioned in those three categories from both the primary stroke centers and comprehensive stroke centers. Currently, our data comes from the comprehensives directly. In the run-up to all of this, we predicted that the proportion of patients who present with stroke-like symptoms in the field transported by our EMS system who would be amenable to these strategies for direct to comprehensive transport would be about 10%. Right now, so we're hovering about 11% of those patients. So we're trying to capture those, that proportion who are likely to get the therapies emerging as being beneficial without moving too many patients around without the benefit to be achieved. One of the concerns about this strategy is whether the additional time, which is only a matter of a few single-digit minutes in transport, bypassing a primary to a comprehensive. It isn't tens of minutes. It averages about 2, actually, but it can vary a bit, but it's still single digits. The concern was and is that any additional time in transport could take away from time for the initiation of thrombolysis. In looking at the median times to thrombolysis for both primary and comprehensive centers, they're very close at 43 and 41 minutes respectively. And that falls within the existing guidelines of the American Heart Association for under 60 minutes. Half the time, which is not a particularly intensive standard, but that's our guideline, but what the AHA is currently working with. So far, the strategy appears to be working. We'll have much more comprehensive information about the long-term functional outcome once the registry is up and running for acute stroke. So let me pause there for a moment and see whether you have more questions, and I can perhaps give you more detail.
If I may, Supervisor, the benefit of the registry is what?
Oh, it's getting the comprehensive data from both primaries and comprehensive centers.
And I know historically we've struggled sometimes to get hospitals to share that information. Yes?
That's right, yes.
Do we think we've now gotten to a place where people are comfortable with that, or is that still a tension in the process?
It's in process. However, we are getting, using traditional methods with Excel type databases now from comprehensive very well. Collecting that data from primaries is still to be achieved, and this registry will help us do that.
Okay, but are the hospitals on board? Because they
are.
Okay,
yes, in fact, the run-up to all of this, we gave a very detailed presentation to our stroke neurology advisory group on exactly what we need to know in terms of outcomes both in the field and in the hospital to give us the analysis we need to assess how well we're treating patients.
And from my perspective, sort of since the early days of this conversation in this committee, we've always struggled with this issue of what I'm going to call assessment, for lack of a more formal term, and the ability of folks in the field to make a correct and accurate assessment in real time about should we go there or should we go there. So a couple of questions around that. You indicated that I believe it was 11% of the folks end up being diverted to a comprehensive stroke center. Is that, do I have that right?
That's correct.
So of those 11%, how many folks, once they're more fully assessed, are we saying, damn, they should have gone to the primary center that was close by?
Well, the distinction between primaries and comprehensives is the addition of the thrombectomy or clot removal technologies. Otherwise, the initial care are the same at both. So, for example, should a patient with stroke-like symptoms arrive at a comprehensive center directly based upon triage acuity, but not be a candidate for thrombectomy, they still will receive thrombolysis. So the effects of the bypass based upon acuity of a stroke patient is not to prevent any therapies from happening, is to increase additional therapy opportunities. So the initial care is the same, both places.
I get that, and I think that you were telling us earlier that the good news is that the delay by virtue of going to a comprehensive center rather than to a primary center is de minimis. It's minimal. You're not terribly concerned about it having an adverse medical impact.
That's right. It doesn't delay the initial therapy.
And that's why I was an advocate for this approach, as you will recall, some time back. That being said, because I really do want to understand the consequences of the path we've taken, of the 11% who show up someplace who otherwise would have gone to a primary care center, are virtually all of them in potential beneficiaries of the more advanced treatment strategies that are available, or is it half of them? I'm just trying to get a sense for, what those field assessments, how good those field assessments are, given the current state of the technology and the training, and I'm going to get to the training in a minute.
Yes, the reference we have so far is the proportion of patients who are delivered to the comprehensive stroke centers who go on to have an identified vessel occlusion. And of those, for the highest acuity, for the triage scoring, about half go on, actually about 70% go on to have one of those vascular occlusions we're looking for. So now, whether they go on to be a candidate for the neurointervention is multifactorial. So we don't judge success on whether they were actually received the procedure. We judge success on whether they were delivered to a facility capable of doing that for further assessment. So it's a triage tool, not a diagnostic tool.
Thank you. And then, given the importance of the assessment, because somebody has to make a difficult decision in literally a split second out in the field, where are we in terms of training for the folks who are obliged to make those judgments?
Yes, the training was conducted back in December of last year, with implementation actually in the same month. That over about a month period, we were able to touch all of the 911 personnel and even non-911 personnel with the combined strategy of time frame for symptoms as well as for stroke acuity scoring.
Okay. And then plans for follow-up, given the fact that people come and go in these positions?
Yes, there is ongoing community education throughout the EMS system for a multitude of things, and updating the stroke strategy is always part of that plan.
But I'm focusing specifically on training new people who will be in those ambulances.
Oh, sure. Yes. So as part of the process for working as a paramedic in particular here, there are three elements. One is licensure at the state level. Another is accreditation, which is a local level, and that's achieving knowledge of our protocols, including the stroke protocol. And the last is being accredited by a provider.
So with respect to any or all of those three, how do I know that somebody who gets hired tomorrow will have the training necessary to make the judgment about whether they take a possible stroke here or there?
When they achieve our accreditation, they will have been through the training of all of our protocols, and that includes the stroke protocol.
Thank you. That was the information I was looking for. Last question, Mr. Chairman. When we had this conversation in years gone by, we had resistance from some hospitals. And there were really, in my judgment, two factors that were in play. One was a concern about economics, and I don't say that disparagingly. That's a real challenge that all of us have to manage, as we've just been discussing for the last hour and 45 minutes. And the other was, judgments about what was medically most appropriate, and you've addressed some of the latter concern in terms of identifying the relatively minimal amount of time that's taken and the number who, in fact, actually are demonstrably benefited by getting to the Comprehensive Stroke Center. So, are we at peace with the various hospitals who are participating now? Have we come to a rough consensus? I'm not asking about right, wrong. I'm more just asking about, do we seem to have achieved a working consensus as we're going forward to implement these? Because for a while we didn't have one, frankly.
That's correct, and I believe we have. In fact, in late July, we had the most recent meeting with the Stroke Neurology Advisory Group, presenting what we discussed here, only in much greater detail with some numerical values, and I believe we are at a point now where, as the science moves and we move with it, we have sufficient consensus anyway to keep our system whole and to be coordinated.
Great. Thank you. Thank you, Mr. Chairman. Appreciate it.
Thank you. And I think you answered that we don't yet have the health outcomes from the hospitals yet. We're still waiting on that.
We have data coming from the comprehensives, not yet primaries.
Okay.
Yes.
And when we have more of that information, you'll
We will, yeah.
put it in the report to us.
The only step in that process still is the approval of the contract with the American Heart Association for the registry. That's it.
And do you think we've reached the point where we have enough comprehensive centers? Or I know I think VMC is still trying to figure out if it wants to be one as well. Or it sounds like the timing-wise, we're okay as far as getting people to a comprehensive center.
You know, I think we'll be able to comment more as we have better outcomes to know. I can relate this to you, though, that over the decades we've learned that concentrating technical resources, for example, our trauma system, and also if, for example, our if a particular acute myocardial infarction heart attack system, concentrating resources in a few centers that perform these procedures on a routine basis improves outcome. So trauma has proven that over the last 30 years. We suspect, and in fact the evidence is along the same line for stroke as well. Our observations is that the bypassing or the triage of acute stroke patients to comprehensive centers is not overwhelming at this point, and they're keeping up. So preliminarily, I would say we're in a good place.
Okay. Just a question not really having to do with stroke centers, but just because a friend of mine recently had a stroke, and I'm looking at your GFAST chart. So if I may, he ended up, he was at work, he actually was a county employee, and had a terrible headache and went home because he just thought he had a migraine headache. And it wasn't until the next morning when he woke up that his young son sort of said, "Daddy, what's wrong?" And that's when he realized that he was having vision problems. Is there are we getting better at trying to communicate to people to call 911 when they think they might have a stroke, or are people still hesitant to say, no, it was something I ate, or I didn't sleep well, or something else?
Yeah, it's a very interesting point, because we have observed with our partners in hospitals that fully half of the diagnosed stroke patients arriving at hospitals arrive outside of the 911 system. So campaigns that raise awareness of stroke symptoms, the urgency of addressing those symptoms, and using 911 for that efficiency, would definitely help.
But again, maybe communicating more as far as signs that you might have a stroke, I think maybe is sort of where I'm going as well, and trying to communicate to people that if you think you've had one, better to call than to go home and see how you feel in the morning,
Yes, that is
guess.
true.
We have one task force outside the stroke committee that Dr. Miller was talking about that we're just forming, and the primary goal of that is community education to call 911 and include those symptoms to try and educate the public. So that is one of those for that very reason, because we found the third year in a row that our data was showing that more people are going by private vehicle to the hospitals instead of calling 911. So we'll definitely head this off as much as we can and partner with the hospitals.
Well, good report. Thank you very much. Michelle, I will get a motion to approve and send it on its way. Does that do it for us? All right. Then we'll adjourn the meeting and see everybody here on September 12th.
telling me to be home.